Hi everybody, welcome tonight. Thank you for joining us. My talk tonight is a lot like our lutetium dotatate or lutate therapy. It's been a collaborative effort and has evolved considerably since its inception. From the idea from this talk, courtesy of Nick, to Claire's pulling together of a PowerPoint for me and everyone else's input in between. I hope that it doesn't appear disjointed. My apologies in advance if it does. As I explored the topic, one of the things that became really clear to me is just how much what we do and how our experience as technologists within this service has changed. The service itself has evolved to meet the needs of our patients, to problem solve issues that have arisen, to accommodate demand for the service with learned experience and with evolving technology. What is lutate therapy? Lutetium dotatate or lutate therapy is used to treat somatostatin receptor expressing neuroendocrine tumours with targeted radionuclide therapy, PRRT. Octreotide is labelled with lutetium-177, which is internalised by the tumour cells, allowing targeted radiotherapy. Lutetium has a half-life of 6.7 days and emits both beta and gamma radiation, making it ideal for therapy as well as post-therapy imaging. The patients referred to for therapy with us all have inoperable progressive metastatic neuroendocrine tumours. By the time they reach us, our patients are all terminal. Our therapy is a palliative treatment only, aiming at controlling worsening carcinoid symptoms and with an ultimate goal of improved quality of life. While it can be difficult working so closely with these patients, given their terminal diagnoses, it's also incredibly rewarding, as lutate has proven to be an option for these patients that has granted them much improved quality of life in most cases. A little bit of history starting the lutate here at the Queen Elizabeth. Our first therapy was undertaken in April 2011 after fact-finding visits to the Peter MacCallum Cancer Centre and the Fremantle Hospital, the only two other sites offering the service in Australia at the time. Our protocols were drafted with the support of those sites, taking the best of the protocols used by each of them with consideration of our needs and our capabilities. The Peter MacCallum was and still are particularly supportive. There was a rising need amongst South Australian patients. Those who could afford to had travelled interstate for treatment. However, the waiting lists were up to a year and the interstate sites began to no longer accept South Australian patients. In addition, Clinical Oncology Society of Australia, or COSA guidelines for the management of neuroendocrine tumours had been published recommending referral of all GEP-NET patients for assessment of eligibility and to facilitate access to therapies by MDTs if indicated. We were uniquely placed to establish the lutate service within our department. The Queen Elizabeth's Nuclear Medicine Department were already offering therapeutic nuclear medicine services and in addition had expertise of specialist oncological and medical physicist staff on site. It was decided that a lutate service should be established here to meet the urgent need of GEP-NET patients in our state. We had a small operational surplus that could be used for that purpose and the availability of space within our new department. Ultimately, we were able to implement the lutate therapy service without requiring further funding or further staff or resources. As we all know, funding is everything. The service was at that time and still is totally unfunded by the government, and this continues to be an issue. Over the last 11 years, we've treated 188 patients, given a total of 471 cycles. We still have patients from that first year returning, one of whom was initially so well that they were unable to leave the ICU and are still returning. The male-female split is about 50-50 and the ages of our patients range widely. The youngest we have treated was 17 at the time, and we treat patients well into their 90s. Most of our patients have a GEP-NET, which is gastroenteropancreatic neuroendocrine tumour. However, some do have other primary sites. Our evolution as a department and the patients we treat, the way we go about our scanning and the patient preparation and care has been driven by a very strong experimental and feedback model of learning. We are constantly evaluating and refining what we do with input from the entire team. A feature of our department is having a highly patient-centred approach to our practice due to the needs of our usual patient cohort. While it's applied across the whole of our day-to-day practice, it's something that's most demonstrably essential in the treatment of our lutate patients who often come to us with highly complex medical and care needs. Increasing patient numbers have been a significant driver of change, resulting in the service itself, the people involved, the role of and our role as technologists within it evolving out of necessity. Our beginning of treating 2 patients every 8 weeks has grown to where we treat 4, sometimes 5 patients every 2 weeks, occasionally weekly if needed. We've consequently added a dedicated net nurse, a net fellow, and a research fellow position to Gabby's team, or the Lutate team. This change in personnel has meant the role of technologists has changed as well. In the early days, we covered many of the roles that now have dedicated personnel. A typical patient pathway is they're diagnosed, they progress, they're referred to the MDT, they're then referred to therapy if suitable. They have a pre-therapy consult, a GFR scan, gallium PET, FDG PET. Then they have therapy 4 times at 8-week intervals, followed up by a consult at 3 months, 6 months, and 12 months. If they progress, they're re-referred to the MDT, referral for retreatment, and then 2 times retreatments at 8-week intervals. All GEP-NET patients are discussed at the monthly statewide GEP-NET MDT. Any patients deemed suitable for lutate therapy are referred to the Queen Elizabeth for consideration. These patients initially come for a pre-therapy consult, often with GFR measurements and renal perfusion on the same day, so it's a big day. From here, they are either scheduled for lutate or put on a pending list if not ready yet, or discharged from the list if they're unsuitable. The first consult they come to, the patient, their support people have an in-depth discussion with Dr. Cekic, Jess, the net nurse, the net fellow, and often others, including the registrars and nurses. Here they review all the patient's clinical information, including the renal scan performed that same day and any previous treatments, blood results, imaging, symptoms, and of course the logistics of lutate therapy. This often includes discussing the potential side effects, any admissions that will need to happen if they are complex, pre-medication, high-risk patients, and for those with significant symptoms. They also discuss transport and accommodation for rural and remote patients. Patients leave this appointment with an information pack, including supportive documentation from the Cancer Council of SA, the Hospital Research Foundation, information about their lutate therapy, and personalised treatment schedule. This personalised approach and the focus on care that accounts for both social wellbeing needs as well as their health considerations is crucial to the success of the patient's therapy. Not being thoroughly screened and planned for can and has led to significant issues down the track. One of the most important is the patient's ability and willingness to comply with instructions, which just can't be overstated. The treatment schedule outlines their, sorry everybody, please. The treatment schedule outlines all of their therapy dates, incorporates co-concurrent chemotherapy when it's required, which is 44% of cases, as well as the timing of all their blood tests, somatostatin or SSA, lanreotide injections. The patients also fill out their first quality of life survey at this point. The quality of life forms are an important tool for everyone in terms of assessment of improvements and for research. All results are collated and in the international REDCap database. Before therapy, once the therapy is planned, there's still a lot of behind the scenes work to be done. Our admin staff book confirmed therapy dates, coordinating with the medical staff, the patients, the senior lab tech, and admissions officers needed. They organise the blood forms, check that they've been done approximately 2 weeks prior to therapy, ensure the correct referral, which can be an issue, and a week before the therapy, they double check the general med bookings to ensure that the required rooms are available for the whole day. The camera is available for scanning in the afternoon and the next morning. The juggle is real. A lot of this work regarding the bloods and so forth is done in conjunction with the net nurse. She's heavily involved with the patient education and support. She builds strong relationships with the patients, ensuring that there's trusted and open communication from the patients. This is incredibly important. Another person involved at this stage is George, our senior lab tech. He is responsible for ordering doses. He orders weeks in advance based on bookings. However, as we are all aware, they are prone to change. He must regularly liaise with all of the staff involved, as well as liaising with Brett and Peter at the Peter Mac Cancer Centre when the orders need to be placed or changed. Peter Mac label the lutate for us and prepare all the amino acids. Rostering is also an important part of this stage, ensuring that the roles that the technologists perform during therapy is rotated. Several different technologists are involved on a therapy day with varied tasks. We rotate the tasks between us to share the dose that we receive. We have a lab tech who just sets up and draws the doses, a technologist rostered to do the administration, another tech to do 4-hour imaging, and if possible, another to do the 24-hour imaging. Elise, one of our techs, presented a research project looking at the times when we received dose and what activities during the day delivered the most dose to us. Amongst other things, she determined that the dose from taking out the gelcos was a point at which one of the highest doses was delivered. As a result, the nursing staff no longer remove all the lines. We alternate who does what, and it's often the 4-hour imaging technologist. We have a therapy record book to keep track as to who has done what and to space that all out. We have also, as a result of Elisa's things, changed the shielding around our administration pump. I'm sorry, I've got a technical glitch, everybody. We changed therapy around, changed shielding around the therapy pump to be more user-friendly because we were finding that some techs couldn't reach and were getting a higher dose due to having to lean around the shielding. Okay, the day before therapy, we do a whole setup as a department. We prepare as much as possible, and med nurses are instrumental in this step, and the techs help out where they can. We change the department around. The space is cleared for the patients. Often the bed bay and the stress room are utilised. Extra beds are ordered, chairs for patients that are unable to lie flat, which is often an issue. It's all set up as shown so that it's ready to go. The pre-meds and IV lines are prepared, and any high-risk patients are admitted the day before therapy to start on an octreotide infusion to help handle their symptoms. An important factor in setup in the picture on the right has been identified through trial and error over the years. It's lining the toilet. One toilet is designated for therapy patients for the day, as a lot of the dose is excreted in their urine. The floor is lined with blueies. Despite asking patients to sit down when they use the toilet and to close the lid when they flush, there's often contamination all over the place, as the blueies show. This has been an ongoing and complicated issue for us. All of this lining is normally done by the physics team, but we all get involved if we need to. We also provide shoe covers that the patients wear when using the toilet, changing them immediately afterwards to prevent any contamination. Patient compliance with all of this is key and not always guaranteed. This year, we've been forced to catheterise a patient for the first time as a last resort. Therapy day, as set up, cast of thousands are involved in therapy day. Admin set all of the patients up, get their questionnaires, their quality of life forms, their admission paperwork all sorted and ready for the doctors. The med and net nurses work together, setting up the patients for therapy. Once comfortable, the patients have baseline OBS are taken and an IV cannula inserted, 2 for the first timers, just in case something goes wrong. Nurses go through the quality of life questionnaires, asking patients about symptoms that they've scored highly. This also includes emotional scoring, pain, diarrhea, personal worries, financial worries. They ensure that they understand and can follow the toileting instructions for radiation safety. They give pre-meds and set up the IV drip of amino acids, which is given to prevent renal toxicity. During this process, the whole team of nurses and doctors conduct last-minute consults, check-ins, blood reviews, symptom checks, and make last-minute changes to the dose and or pre-medication if necessary. At this point, therapy can also be cancelled if patients are extremely unwell. For the techs, on delivery of the labelled lutate, the tech rostered in the lab will unpack the box, systematically check each piece of waste removed for contamination before disposal. This has been proven to be a far more regular problem than you would imagine. They will then remove the amino acids, first measuring the packaging for contamination before handing over to the nursing staff. Next, we draw up the lutate doses with another tech as a spotter. They double check everything, record the delivered amounts in a spreadsheet, as well as writing down the measurements and the dose stickers. The drawn up dose is 7.4 to 7.8 gigabecs. This is based on the multi-center NETA trial out of America, which was used to gain FDA approval for therapy in the US. We draw up approximately 8 gigs to allow for a residual that's often between 200 and 300 megabecs. A small 10 megabec standard is also prepared, measured and labelled, ready to be placed next to the patients during scanning. Residual activity is then measured, labelled and stored for decay. The administration trolley is also set up with a pump wrapped in plastic to prevent contamination and placed behind the lead shield. A sharp spin is prepared and shielded, and 150 ml syringe for each patient is filled with saline and connected to a 3-way tap and extension tubing. A timer is also glove wrapped. From experience, this is necessary, and they're ready to go. Therapy day, the administration. It's done one patient at a time. After the amino acid infusions have been running for about 30 minutes, the luteate admission can begin. Patients are usually located quite deliberately. First timers will be in a room with a patient who's had at least one luteate treatment previously. This patient usually gets treated first so that the first timer can see the process in action. They are often quite anxious, and being able to see it in action really helps. The tech rostered on to administer the luteate will ensure the patient due to receive luteate next is ready. They should use the toilet, their amino acid infusion should be stopped and clamped, and their gel code should be checked for patency. The shielded trolley with pump is then set up next to the patient, lines are connected and tested, and luteate therapy begins. Therapy day, administration protocol. A standard dose of 7.8 gig is administered by slow infusion using a pump. The dose is usually about 1.5 ml in volume in a shielded syringe and is connected to the tubing via a 3-way tap. The dose is manually pushed into the tubing, and then the pump is used to push the dose through to the gel code/tubing junction. The pump is then set for a slow infusion of 20 mils per hour over 15 minutes. This protocol has developed over time and with experience. With our initial slightly faster infusion, the few patients who did experience side effects felt them more intensely than they do now that we infuse more slowly. After the initial slow infusion, the pump is set to a faster rate of 200 mils per hour for an additional 5 minutes to flush the tubing and ensure all the dose is delivered. During this 20-minute period, the administering tech will also measure the residual dose from the syringe, as well as checking for contamination on the lead shield pot used. A varying combination of net nurse, newt med nurse, newt med consult, newt med register, net fellow, and technologists, cast of thousands, will observe the patient through their treatment. We stand on the other side of the lead glass shield, engaging the patient in conversation, watching and listening for side effects which are recorded. And in rare cases, the side effects that are significant, medical staff manage these as necessary. Each patient has a lengthy standard EPAS entry for therapy, which is constantly added to throughout the day by nursing staff and uploaded at the end of the therapy day. Treatment is often quite anticlimactic for the patients. In the event that they do experience side effects, the most common are flushing and nausea, usually treated with a cold flannel and then often passing after a few short minutes. Interestingly, the way in which a patient reacts on their first day is almost always the same or less on consequent treatments. The timing is usually around 5 minutes if it's going to happen. After the treatment, the pump is disconnected and the amino acids infusion is recommenced. They run for a total of 4 hours. The patients now sit, chat, read, eat lunch, and nap into their 4-hour post-therapy scans. During this time, medical physicists will also come and measure them and measure their patient dose rates. They give them the all clear when they're below 25 microsieverts per hour. Okay, on to our scanning. On the day of therapy, all patients have a 4-hour post-therapy whole body run. This is a 15-minute head-to-toe acquisition, much like a bone scan, except that it's acquired with medium energy collimators. The pre-prepared point source is always included and is always placed above the right shoulder, except in my example, for easy location and recognition of what is in every scan. It's used for the 2-day scanning as well. The precise amount of the point source, time it's drawn, the height and weight of the patient, the initial dose drawn, and the time of injection and the residual are all recorded on every scan acquisition for use in dosimetry and quantitation. As I outlined before, the technologist who scans the patient at 4 hours is usually, where possible, different to the lab and administering techs. This tech often removes the gel coat at the end of the day as well, and these tasks are amongst the highest dose receiving tasks. After scanning, our patients, having been given the all clear by the physicists, are then given an appointment letter for the next day with their day 2 scan times and discharge medications, and finally they can head home after a really long day. Patients come back the day after therapy, often early in the morning, for their day 2 scans. This schedule has changed a bit recently, and we now have settled on triple spec CT scans for all patients after all cycles, except when not tolerated by the patient. Spec CT acquisition ends up being about 35 minutes long, so it's important that we take extra care to make the patients as comfortable as possible, with their often significant abdominal disease making that quite difficult at times. This is a challenge we've all become quite practiced at, and we have various instruments like padding and instruments around to make them as comfortable as possible. After the day 2 scans, the NET team, Dr. Chekic and her others that work with her, will speak to the patients again. It's a comprehensive consult, often lasting an hour. Patients are shown their imaging and it's explained to them, and the repeat treatments and comparisons are also shown and outlined. After an 8-week break, patients return to us for a repeat dose and up to 4 times for their initial treatment cycle. It's changed if it no longer suits the patient, or if the patient is having side effects. So it's not always exactly 4 cycles. We have this year, for the first time, had a patient who had a response in that they had minimal uptake on their second therapy scan, so much so that the rest of the treatments have been halted while he's restaged. This is exciting, and we look forward to following his progress. At 3 and 12 months post-therapy, patients return for yet another consult. Here they fill in the quality of life surveys again and review the markers of response, mainly blood results, imaging, and the quality of life. At this stage, we often see a real improvement in that, and our patients leave with survivorship paperwork, often not presenting back to us for another few years. We routinely do repeat therapy, up to 4 treatments again, in patients who have had a good response from lutetium previously and have represented with worsening symptoms again. One of our patients has returned for a total of 12 treatments. Some of the reasons for ceasing or for not continuing with therapy for the patients include these rarely seen occasional issues faced by them. They outlined here. It's not something that we see often, but it's something that's worth mentioning, that it can be an issue. Issues faced for us. So one of the big problems that we have is delivery issues. We've had issues with the supply of lutate due to when it was initially delivered to us from Holland, with storms overseas affecting flights, and due to the dose simply being put off of a plane because the pilot deems it too dangerous. We moved to sourcing it from Ansto, but that's brought about different supply issues in terms of their technical problems, and it hasn't solved the pilot factor. The dose was put off the plane in the last month and again today. Today it hasn't arrived yet, and it may as yet be the wrong one. Contamination is another major issue for us. We deal with the contamination in terms of spills, with the lutate, with its contaminants from its parents' isotope, have issues with the patients themselves due to patient compliance, patient cognition and their ability to follow instructions, and their possible urgency or incontinence issues. We also have trouble sometimes with room in balancing our regular nuke med work with the therapy on the therapy days, particularly as our therapy has become more regular. Again, and that includes camera time. We have had issues with irradiation exposure to our staff, but studies by our staff have helped improve that. That's something that's an ongoing improvement, ongoing assessment thing. At least a study resulting in better shielding and in the alternation and sharing of tasks. And another one of our tests with a literature review changed the way we use our PE and what PPE we use to protect ourselves from the beta rays. And the patient issues, as I've mentioned over time. This patient is worthwhile looking at because this for us was a perfect storm. This was a combination of compliance issues, a continence issue, and contamination issue. The patient didn't let us know that he had issues with continence, also didn't let us know that he had had an accident and wet his pants. So we had an issue with the patient being contaminated himself. And unfortunately for this patient, it was one of the doses of lutate that had contamination from the parent isotope. This has resulted in this person won't be getting their pants back for over 18 months. Okay, future directions for us. Ongoing contribution to the international studies by way and data collection and the studies that they lead to via REDCap. Continue involvement in the quality of life collection and the information that that brings forward in terms of research and in terms of making an argument for the funding of lutetium, given that it is a very effective and very useful therapy. Looking at collaborations, involved with collaborations with educational, medical and research institutions. We're hoping that the increased involvement with trials and the ongoing collation of our data and demonstration of how effective and how useful this therapy is will help with growth of the department and with the funding particularly. And one of the last things, so the most important things, I think, and exciting things for me is securing our own supply of lutetium. George has sent a test dose with a view to experimenting with and organising the ability for us to be labelling lutate here in South Australia and also producing our own amino acids, which hopefully will help our supply issues. So a couple of things that have changed over time, as I mentioned in the beginning. These are a couple of images that show some of the progressions over time. One of our pre-treatment imaging requirements was a indium 111 pentriotide or a test dose of lutetium octreotide scan. In the first image you can see, we then have moved to using PETs to stage the patients and to show that they are suitable for therapy, and you can see the difference that that makes. One of the other things that has changed over time is initially we were only staging or checking the suitability of patients with an FDG PET, and then gallium PETs became available. We were finding that patients were not necessarily responding the way we would expect, and with the introduction of the gallium PET, we were able to show patients who had a mixed type of tumour, and it became evident that the patients who had high FDG avid disease and not gallium avid disease were the ones that were not progressing like we would hope. What we're working on at the moment, we're looking at global SUVs as a way of quantitation. I mentioned earlier a patient that has, sorry, lost you. I mentioned earlier a patient that we had that had on their second therapy far less uptake of the lutate in their tumours, and therefore they are being restaged. This is images showing this patient. Their initial uptake, according to our global SUVs, was 12.8% of the dose, and on their second scanning, it was only 0.34% of the dose. We've been working with the global SUVs as a way of demonstrating the reduction in tumour burden, or at least the reduction in uptake of the tumours in a patient over time. There are some drawbacks and difficulties with that, and it is still a work in progress, but we are showing good sort of intra-technologist and inter-technologist results where we're quite accurate in terms of our processing, and we're able to show this for this patient. Final comments on us as a department with lutetium. The fact that current global issues have demonstrated conclusively that we really need to be self-sufficient in order to offer the most streamlined and efficient service possible. As we grow, we need to be self-sufficient in what we do. For our service to stand alone, literally, and to grow into full maturity as we look to take on other kinds of therapy using lutetium, and as we look to being able to do our own labelling here, we're also exploring the idea of a synthesizer that will do that for us. That's one of our main focuses going forward. The other thing that I think is really crucial is we're the only therapy unit of our kind in Australia without on-site PET facilities. We are currently in the application process for our own PET unit. Watch this space. Thank you, everybody.